3, 2, 1, starts with and go. Hi there, I'm Dr. Lisa Cassileth, and this is
Dr. Heather Richardson.
We are two physicians who treat breast cancer, and we're here to talk to you today, and most importantly, talk to our amazing patient and patient advocate, Alejandra Campoverdi, who is, aside from just a fabulous person in general, she also has been through her personal journey with BRCA2, has had a bilateral mastectomy, and is just an incredible patient advocate. She herself has shared her journey through this diagnosis and then what she's done about it. In addition, she has created her own film called Inheritance that really goes through her own journey. So it's an honor and privilege to have her here and to be her doctor. So fantastic. Welcome, Alejandra.
Thank you. This is a dream team. I was just saying when we first got on the Zoom, because I couldn't feel in better hands than with these two doctors.
Thank you so much. I'm a plastic surgeon. For those of you who don't know me, Dr. Heather Richardson is a breast surgeon. So we work together a lot. Heather treats the breast cancer or people with high risk of breast cancer. And then I do reconstructions where it's appropriate to do mastectomies. And so really try to make people look their level of what they're comfortable with. Hopefully completely normal is what we're going for. Alejandra, you are no stranger to knowing that this is not necessarily an easy process, as you've been through a couple surgeries yourself. And then I think, where we want to start off is just talking about some of the things you've been through, Alejandra, how you were diagnosed. And also, how can, there's different recommendations for different people with BRCA. How do we manage that gene and how do we treat people with the BRCA gene?
Yeah, my journey, I won't say I did everything perfectly because I didn't, but that helped me to learn a lot and get to the point where I did. So I'm very happy to share that because I'm hoping that by sharing this kind of twisty, turny journey for me, it can help folks skip some of those steps and extra surgeries and extra cost and all of that. But I've been very fortunate. I first started getting an idea that maybe there was something going on with my family because my great-grandmother, grandmother, mom, and 2 aunts have all had breast cancer. So when I was in my early 30s and I was in the around 2013, I heard about BRCA and I thought, well, maybe this is what's going on with my family. So actually when I asked my gynecologist for a test, so it was back then, it was like a really expensive blood test and it was a really complicated thing. And I found out that I was positive. That's one of the great things right now. It doesn't have to be so complicated anymore. It's actually super easy, super cheap. A lot of places you can find will help you test for free or insurance will cover it. So I went through that experience, found out I tested positive and decided that I would have the preventative double mastectomy. Fast forward to 2018, I'd been doing the screening and the MRIs with contrast and everything they were supposed to be doing, the CA-125s around the ovarian cancer risk. And I had my double mastectomy. Now, again, you plan everything you can, and I didn't expect what ended up happening, which was about 6 days after when the tissue that they removed was tested, they discovered a DCIS, stage 0 breast cancer had already started developing and had not been detected because it was so small at that point. Thankfully, because of the timing of everything, I didn't have to have any further treatment than the surgery. But that wasn't a one and done, which is what brought me later to Dr. Cassileth and how she's been such a lifesaver for me to be able to get through this actually feeling okay in my body, because once, I took care of that risk, there was still the matter of the reconstruction. And so I've had 2 additional surgeries, reconstruction surgeries, and I'm happy to answer whatever questions because as I'm sure people know that are watching, there's so many different choices above the muscle, under the muscle, nipple sparing. There's just so much information to take in. But when you're in the right hands and you have a partner, a doctor standing by your side to help you navigate it, it is so much easier and you feel so much more confident. So I'm really excited about this conversation and especially your questions, because if I had had this conversation at the beginning of my journey, I would have saved myself 2 surgeries, almost probably like tens of thousands of dollars and just a lot of recovery. So I'm excited to be here and talk about this.
We definitely want to get any questions from anyone watching, and please use as a question and answer feature. Alejandra's got great answers, and we would love to answer your questions too. So for sure, everyone out there can type any questions and our team will get them to us.
Heather, something that actually my patients ask me a lot is that when they're seeing me for prophylactic reconstruction, they say, what do you think, when should I get this done? Should I do this right now? What do you tell people about when this should happen?
Well, first of all, we want to make sure that we have a really clear understanding of what the family history is. So we want to know what the what the pattern of disease is in the family. Now, Alejandra, you had some of your relatives were older, but as the decades went on and the generations went on, it got younger and younger, didn't it?
That's a perfect point. And you could see that in my family. My great-grandmother was in her 70s. My grandmother was in her 60s. My mom was 49. And when I was diagnosed, I was 38.
Right.
So they had initially told me the same thing.
So the formal recommendations are that people with a documented BRCA mutation should consider having a prophylactic mastectomy between 35 and 40, but also looking at the pattern in the family and maybe catering it to the person as well to answer your question.
I mean, it's also very tricky because, we all have that like terrible story. I had a patient she was actually the rep for Allergan, which is actually one of the biggest implant companies that exists in the United States. And so she had been like surveying everyone in Beverly Hills to pick her doctor. I felt very honored to pick me. And so she said, you know what? I'm 35, I'm gonna have a baby, and then so I can breastfeed, and then I'm going to do this. So we're like, okay, this seems very reasonable. Now she found out she had it on a screening test, and her dad was the carrier. So she didn't have a mom to know what age that her mom had it. And then the other was, as it sometimes happens with grandparents, kind of like, oh, I think she had it. Oh, maybe it was this age. Oh, we don't know. Right. So that was
people are much more secretive about their health history.
Yes. And people may not even know, and you won't know until the very end. So she chose to do this. And then when she felt a lump when she was breastfeeding, and then we ended up diagnosing, she had 2 different cancers when we did the mastectomy after the baby was born. Now she's being diagnosed on chemo with a 2-month-old. It was just so depressing. She ended up with the worst possible story, which is dying of disease, even though this is such a curable disease normally. And it scared the crap out of me. So, unlike I am not a surgical oncologist. So when people ask me, when would you do this? I'm like, get them out, there's Gary, but that's not what you say. You say 35 to 40.
35 to 40 is the general recommendation. But again, there is no wrong or right answer. And that's why you always want to do it for the patient. You refer to the family history, you talk about the patient's anxiety. In your documentary, you had really amazing stories. I mean, you had a story of a sister who was found out immediately that she had the BRCA gene, went forward with the prophylactic surgery, and she and her father begged the other sister, and the other sister said, I'm just not ready to test.
Mm-hmm. She wasn't ready to test. Not only not ready to have the surgery, but not ready to even know if she carried the BRCA gene. Unfortunately, in her case, she was diagnosed with breast cancer. I'm not a doctor, so my best advice around this question, which I've thought about a lot, and I get this question a lot, is really listen to your gut, because this decision is so hard. It seems like you're hearing different information. Usually around the time is exactly what Dr. Richardson said. You don't hear conflicting information about when, but I had people telling me, you're so young, why would you do this? Or you may not get cancer, and everyone has an opinion, especially when you're doing something like this prophylactically. But I felt in my gut, I knew that something was going to develop. I just felt it. And even like the night before, I was like, oh, I don't know. And I said, nope, I know. And not everyone gets like the instant validation that I did, that it was the right timing. But if that can be like a validation to anyone about the fact that it could potentially be around the corner, and how would it feel if you were diagnosed like the woman in the documentary, when you knew that you could have had surgery beforehand? To me, that would have been harder than anything. So that's why I made that choice.
Right. And everybody's choice is their own. I wouldn't say anything is wrong or right, but what I found in my experience is that most people not knowing is the worst. And when you have sort of the fear of the unknown, people pretty much automatically assume and live with the worst, which a lot of times people get tested and there's a 50% chance that someone, if you have a first degree relative, a mother or sister or father or brother with the gene, there's a chance at 50% chance you don't have the gene. And I mean, that's the clouds part and the sun comes out, there's a big rainbow. All of a sudden you don't have that same risk as your other family members. It's like you married into the family or were adopted into the family. Mm-hmm. And that black cloud that's hanging over the other family members is no longer hanging over you. So I think the information is very important to have. And I found most people so many people I hear, well, if I know that I have the gene, I'm going to have so much more anxiety. I'm going to have so much more worry. I think then it's sort of like the road forks. Instead of this being this fog over the road, you have a fork in the road. You have two choices. You're going to do this or this. Yeah. And I feel like more information and more choices is even better. And I saw you on your journey that you documented with your wonderful film. You made choices along the way, and you even said, there were moments where you didn't feel so certain, and then you could tell like, okay, now it's time.
And thank you for saying that about that there isn't one right answer, because I certainly, don't encourage folks to make any decision that they don't feel 100% confident with. It's such a personal decision. But, to your point, when I tested first in my family, so I kind of tested and told my mom and my mom and my aunts and my sister and everyone else to test. And that's an important part too, is that like finding out this information for yourself could ripple through your family, and could potentially end up saving your family's lives. Both my mom and my aunt have had prophylactic, their ovaries removed prophylactically because of this information. And in the beginning, my mom didn't want to know, same kind of thing. But then she was really scared of what it would do to her to know. But after she knew, now she can have like screening. Now she can be on top of it. So if God forbid something happens, she catches it sooner.
And then what is on top of it? What do you recommend when someone comes in and they decided they're not ready for a mastectomy and they want to just follow? What do you recommend?
So it depends on the type of gene, and everyone knows about BRCA, BRCA 1 and 2. Those are the heavy hitters. Those are the A-list celebrity genes that we all know about. But there's a lot of there's a lot of B-list genes out there too. There's a lot of other players that we would want to know about. And the recommendations might be different for different genes. For some patients, the risk is very high. We can, with data, we can see that a huge number of women will go on to develop cancer and much more higher predictability. For BRCA 1 and 2, 60 to 80%. Some studies, maybe even higher. For patients with other different types of genes, like the CHEK2 gene, it's a really wide range. It's somewhere between 20 and 70%. So if someone has the CHEK2 gene, are they on the 20% end or the 70% end? It can be a little bit difficult to navigate. How much does someone have to worry about that, and how proactive do we need to be? For patients with the BRCA1 and BRCA2 gene, if they're waiting in a holding pattern and they're not quite ready to perform any prophylactic surgery, or if they think maybe they might never be ready, that is the one group that should have an MRI every year, and they should have a clinical exam at least once or twice a year, and then they should have a 3D tomosynthesis type mammogram once a year as well. And then I love ultrasound. It's so immediate. It's instant gratification, and looking through with the ultrasound there's no radiation, there's no compression. You can do it twice a year, you can do it once a year. So I curtail a special custom plan to each patient, but definitely want to include an MRI and a mammogram once a year. MRIs need to start at about 25 to 29. Mammograms should start at 30, or looking at the family history of the youngest family member, we want to start with 10 years before that. And then girls who know that.
I say that again. I love that fact. You look at the youngest family member who ever had breast cancer and you subtract 10 years, which I love that, because I've not heard that. And now I've been saying it makes so much sense, because you don't want to start looking when, your mom had cancer at that age. You want to start looking earlier, but you're not going to start looking when you're 20. Well, if she had it at 45, right? So there's very reasonable.
Yeah. For instance, Alejandra, yourself, you had DCIS, a very tiny area of pre-invasive stage 0 cancer in a very small part of your breast that wasn't able to be seen. That would have probably grown and progressed. It probably would have been another 5 to 7 years before we would have caught that as an invasive cancer. So here we are 10 years before your other.
That was lucky.
So we were right in that window. We were right in that window where that was where the seeds were starting to germinate, and and it was caught perfectly. And now here you are with a Excellent prognosis.
And can I say, because I won't shut up about these things. If you're watching and waiting, there's a lot of things you can do with your nutrition and your diet that lowers your risk of breast cancer. Also do all those things, because you're taking something that you're walking around with a risk factor of. Do all those things that matter more in you than they would to just the regular population, which is already a 1 in 8 breast cancer risk population. So if you're going to say watch and wait, then also, make sure you have soy and flaxseed in your diet. Make sure that you're eating as little amount, close to a vegan or whole foods diet. Make sure you're not overweight, because excess fat produces estrogen and is a stimulant. Like all those things. Why? Because it matters most in you. So, that's really true for all women, because our risk is just so high living in this country, but even more important for BRCAs.
And for patients in a gray zone that they clearly have a family history, they've got multiple relatives with cancer, and yet, their aunt has done the test, their cousin's done the test, and they had cancer and they're negative. And it's like, well, I don't have the gene. What does this mean? And it means that there's clearly something going on in your family that people can share with each other. So it's either genes that are working together, and those genes are otherwise normal genes, but they're normal genes in and of themselves, but yet that combination isn't so great. Or that there is a broken gene that we don't have a test for yet. There hasn't been a scientist that it says, okay, this loci right here, that's a problem. So with that being said, diet and exercise. And sometimes people want to know these things, so that people like specifics.
I like that. Cup of soy a day.
Cup of soy a day.
2 tablespoons of flaxseed. 2 tablespoons of flaxseed. Those are the big 2.
Big. Those are my favorites. And then I love vitamin D. I want my patients,
vitamin D. Yes.
I want my patients to have a vitamin D level of 70 to 90. That's good. Now this is the tough part. This is like it's like I'm more likely to go into space than I am to do this, but 3 drinks a week.
Oh, 3 drinks a week.
3 drinks a week. I'm going to be an astronaut.
You're down
before that happens. I'm like 4 drinks a week.
That's not bad.
That's it.
But really is supposed to be 3 or less.
It's supposed to be 2 or 3 or less is ideal. And then exercise. We want 160 minutes of exercise a week. So that's 4 40-minute sessions. If you want to,
we don't have to do CrossFit, do we?
I don't know, Alejandra, what do you like? What's your recommendation?
Because I think I got like a walk.
I'm a hiker.
Great. Yeah. Get your heart rate up, get out there, get your dog, enjoy this beautiful world. And
what I was going to say is stress levels in general too, because just like the inflammation in your body, like I had to, we get a diagnosis at 38 years old, even if I caught it early, you think, okay, well, my body started going in that direction. Like what was going on? What's going on with my body? And a big thing is, kind of not learning how to like regulate your nervous system, talking about myself, and trying to find better coping mechanisms, learning to meditate, all those different things. Like, I feel like it all contributes. And it was important to me, if I'm going to have a surgery like this and have a double mastectomy, it isn't over, just because you have the surgery. Like, well, how do you make your body incompatible to breast cancer for the rest of your life?
So true.
Super important.
And I have a lot of patients reminding me, because they'll see me working like a dog, and they're just like, Lisa, you cannot burn the candle at both ends. This is not good for you. You can't recuperate if you just, are just stressed out all the time. So it's really, I think women in general are terrible at balance because we'll assign ourselves the hardest task and hold ourselves responsible for everything. But that's really important to figure out how to do exactly what you're doing,
Somebody had tossed up a question about benign cysts, and should you?
Oh, thank you for.
And it wasn't really clear to me if they were talking about if you had a broken gene and you had benign cysts.
Well, if you have, this is what I kind of took it, and this is what I've heard too. If you have cysts or very cystic breasts, and do you need to follow more carefully also? And if you have BRCA and you have cysts, are you at higher risk in some way? What do you do with a cyst?
Right. So fluid-filled cyst bubbles, as long as that's honestly what we think they are, and there's no question that it's a cyst masquerading as something else. If it's just a fluid-filled cyst bubble, breast tissue's job is to make fluid. That's what it does. Sometimes the tissue creates more fluid than it needs to, and you'll get some of the fluid captured and stuck in the tissue, and it'll make a little bubble of fluid. So that isn't dangerous. It isn't bad. It doesn't increase any risk of future cancer by having fluid come and go in the breast tissue any more than if you have pimples on your face where there's inflammation in little areas that come and go on your face. That's not going to lead to skin cancer later on in life. So totally unrelated. fluid-filled.
But it's harder to see. That's the only thing, right? Because
Well,
if you've
it's
got a lot of
harder
busy,
to
busy.
feel. If you have,
Right.
if you're feeling your breast tissue
Well,
and you feel a lot of lumpy lumps, and that sends you, you know, reeling because you're worried that all of those lumps might be cancer lumps, it's very simple. The best test for that is ultrasound. So it's very, very simple to look through the tissue with ultrasound and to get the evaluation of the tissue with ultrasound. And then if we clearly think it's just fluid-filled cysts, we can reassure you. And if something changes, we can reassess anything that comes up in the future. But otherwise, no, people with fluid-filled cysts don't need any extra special testing or need to worry with whether you're gene positive or gene negative. It's true for both. And then someone asked about BRCA testing, like how often should you test? Well, once you know if you're positive or negative for the genes that are tested for, that shouldn't change. So it's not something that if you've been tested, you should repeat it. So once it's true, it's true. And if it's false, then it's false. And that additional information shouldn't change. But for instance, if you have a very strong family history with multiple family members that have had cancer and people were tested and we didn't find anything, well, 10 or 15 years ago, we only tested for 2 or 3 genes. So every 10 to 15 years, if you don't have a definitive answer, you should probably maybe retest in 10 or 15 years to see, aha, have we found a new gene? Have we found a link or an explanation? But otherwise, if you're positive and you know that you're positive, all we need to look for is that one gene. We don't need to look at all of your genes or 700 genes. We just need to see if mom has the BRCA2 gene, you're her daughter, do you share it or not? And either the answer is you got a good copy from mom and then you got dad's copy, or you got a bad copy from mom and then dad's copy. So which is it? And it's just that answer, yes or no, and then you don't need to repeat the test any other time.
And if you have ovarian cancer in your family, should you test them?
Yes, ovarian cancer for sure, and even higher association with genetic abnormalities, especially if you have Ashkenazi Jewish heritage. Now, Alejandra, you had a really great point, and of course, you're such an advocate for people of color and the Latino population. You had a really great point in your documentary that this gene can mutate in any population, in any race, in anywhere in the world. It's not, a lot of us think that it's a Jewish gene, that it's something that happens in the Jewish population. And if you have the broken gene, that means somewhere you have Jewish ancestry in you. And that's
I think it's 1 in 40 in the Ashkenazi population, which is why there's that association. Ironically, when I did 23andMe, I discovered I have some Ashkenazi. So that's actually probably where, so that's actually probably where it came from for me. That said, the second highest group is Latino community, Latinas. And so that's one of the reasons why I partnered with Penn Medicine to start LATINX BRCA. And so for anyone here who may have a Spanish speaker or be of Hispanic descent, this is an initiative about raising awareness, specifically with that community, to have access to Spanish language genetic counselors and all this information we're talking about in Spanish, because there are still a lot of populations that don't even know BRCA exists. You know, that's why webinars like this are so important, because you think that when you go to the doctor, everyone knows, but my own little sister with all of my family history went to the doctor and they said, oh, you don't need a BRCA test, not for like another 10 years or something like that. So there's still a lot of misinformation in every community. And
I had a patient yesterday tell me that a doctor told her just 2 years ago that she didn't need to have any genetic testing done because all of the breast cancer was on her father's side. And because it was on her father's side, she couldn't get it. And I was like, that's not right at all.
You know, maybe he didn't go to med school. I think that was how that worked.
I don't know. Maybe he was a vet. Actually, vets are great.
No, we have a testing in our office that we do and we can give patients. And where else can you commonly find it? Can people just go to their local doctor? OBGYNs often have it, right?
There are a lot of doctors' offices that will offer testing now. And I think you showcased color on your documentary. There are several commercially available tests that people can do. We just want to make sure that people understand what questions we're asking and what kind of answers we're going to get from those questions. So for instance, hey, I sent in my spit test and they sent me something back that says, I'm likely to get migraine headaches and my eye, my eye color is, this much percentage or whatever. And I have, some Slovak and some Filipino in me. That doesn't, just because it doesn't say you have a gene doesn't mean there's not one there. And just because one of the most common genes might not be flagged or showcased, it doesn't mean that there might be another secondary gene that might be there that they just didn't highlight. And also, even if it's all negative, it doesn't mean you can't get cancer. So I think you mentioned that your aunt.
Yeah, my aunt was actually diagnosed with breast cancer right before I had my double mastectomy, and she tested negative for BRCA. So my mom is one of 4 sisters, 2 had BRCA and 2 didn't, to make your point. And, I took a BRCA test, the blood test, but then I retook it just to make absolute sure before, and I did that in the documentary, just to make absolute sure before I did the double mastectomy. But it is really that easy now to spit in a tube. And, I've had people tell me that they've been turned away by their doctors. And with this isn't a commercial, no one's paying me, but with companies like Color, you can order one yourself.
Yeah.
It's like $100 or so and find out.
Right. And we can make that website available to people so you can log on and get it. I mean, at this point, I feel like it's very easy to test. They test for a whole host of other genes. It's great to know. And so I think, if we have resources so that everybody can find out if they want to know, right? Hey, can we get to something that I think I'm really super passionate about too?
Yes.
One thing I love about patients that have prophylactic mastectomies or BRCA is that they have time to do research and make decisions.
Yes.
And so
you did a lot of research.
It's very important that they choose the right doctors. And we aren't the only doctors in the country. There are lots of other good doctors. And I think it's important to ask the right questions. And so, you're choosing really a minimum of 2 doctors, the plastic surgeon and the breast surgeon who does the mastectomy. And so a lot of people don't know, but when you have a generic, breast surgeon do your mastectomy, the chances, all untold, of you having something happen to the skin overlying, if you can imagine, you're actually making a cut and coming very close to the skin and taking the breast tissue out from under the subcutaneous fat. So if you can imagine, that involves risk, right? So that the chances of, if you use just a generic surgeon, of some of that skin or overlying tissue, the nipple or the areola, dying is incredibly high. It's over 33%. So when I always tell patients, even if they call me and they're in Canada or Australia or across the country and they're like, I can't get to you, I said, ask your surgeon, what is the rate of mastectomy flap necrosis, right? And so I got really lucky. I get to choose the surgeon I work with. Heather's rate and our other doctor, Dr. Leslie Memsick's rate, is less than 1%. And why is that important? Because when I do my plastic surgical reconstruction, if I am going through her incision and using the skin, the nipple, the areolar overlying, I need that to be healthy. I need it to be normal. All the breast tissue is gone, and it's a safe and healthy total mastectomy. And I don't know why it's so hard, Heather. I watch her do it. She's like, la da da, like usually perfectly going through the tissue.
I think it's pretty easy, but
yeah.
I like it.
But I think after you do it correctly for a long time, you can see the plane between the subcutaneous fat and the breast, and then they just track it exactly in that plane. Is that what you feel you're doing?
I like to describe it as, think about it like an orange, like a navel orange, where the fruit kind of comes up and erupts.
She's big on analogies.
Through the top of the orange. So the breast is kind of like that. It's actually, it's a modified sweat gland. So it starts as an organ in the skin. Its little bud is inside the skin, and then it erupts underneath and kind of grows and develops underneath that. But then that one part where the nipple is and the areola is, that's still erupting through the skin. So that part's inherent with the skin. So I think about it like an orange, where you've got the waxy layer, you've got the white and fluffy layer, and then you've got the fruit. So the breast tissue that could hurt people and spawn cancer erupts through the skin at the nipple. And it's sort of like the fruit layer. The white fluffy layer is the fat. So I have a lot of fat, and I have fat on my tummy, I have fat on my arm, I have fat on my back, and that skin and fat layer sits on top of the breast. So the breast kind of erupts underneath it. So a lot of doctors say, I'm going to get it all. I'm going to leave nothing but skin. And the problem with that is that the healthy fat that's sitting on top of the breast tissue is not hurting anything, and it's not part of the breast, only where the nipple erupts up into it. Now, the breast tissue does kind of stick to the skin like spider webs, and has a couple of little points where it anchors to it, and no doctor can get all of it. I always like to remind people that 5 to 7% of women have breast gland tissue in their armpit, And so I know of 0 doctors who routinely cut out armpit tissue to get it all.
Right.
So I feel like the best way to say it is we're going to get all of the tissue that matters, all of the cohesive breast gland tissue. We're not going to leave anything behind. We're not going to leave anything that could hurt you. But we also know we can't eradicate every breast cell because some of it is stuck to the skin, some of it is stuck to the.
And it doesn't matter if you do.
No, people do great.
And that's the crazy thing. So they did studies, and this has been now years where this has been a totally accepted form of a mastectomy, is leaving the nipple and areola. Alejandra, when you did it, it was like a little bit more like, ooh, not everybody was doing it. Now I think it's getting to be more frequent. It's still not necessarily a standard of care though, because for years we did the mastectomy. We, whatever, everybody,
Yes, my fault.
your people,
my camp, my people.
did it with a big cut, because it frankly is just a simpler operation to do, and it was felt that was safer. And then when they finally looked at not 1 study, not 2 studies, but over 10 studies comparing nipple-sparing mastectomy to where the old school one where they did the cut, they found that the recurrence rate was either exactly the same or actually slightly higher in the people that had the big cut.
And those are for cancer
shocking.
patients. Those are for surgeries that are being performed on patients with cancer.
Exactly correct. So that means if you're doing a prophylactic mastectomy, the chances of getting cancer afterwards and residual tissue would be no different, very, very, very low in both cases, whether you did a prophylactic nipple-sparing or non-nipple-sparing mastectomy. So of course, because aesthetically, the nipple-sparing mastectomy is usually far, far superior, you really can have it look like a normal breast. And that's about me doing my part right. And, it's a big debate for a while, over versus under the muscle, which you're very familiar with. And I think now we're like very over the muscle. Right.
Let's leave things alone. Let's leave.
I'm very glad with my decision. That was the right decision for me.
That was the right decision. Absolutely. And I think, there are still people, I think most people probably still go under at this point, but it's getting more common to go over because the patients are so much happier. It hurts so much less. And then there's also ways to do the plastic surgical part of the technique that it comes out better. Right. So like if you can imagine it, if you're putting in an implant, you can there's something called dermal matrix we traditionally use when we do direct to implant reconstruction. So the dermal matrix can be put in all kinds of variety of different ways, but the way that really it comes out the best, if you can imagine, is if you make a full bra and you slope the top. If I wrap it on the back table, I'm like, oh, Heather, you're done. I just pop that right in. It's like it rolls, the skin rolls over it. And so doing it a more careful way, actually constructing how you want it to look with the patient, so you can sit them up and look at it. You can get the slope right, so you don't get a fake top. And then the implants, which are often used, are cohesive gels, don't ripple like the old ones do. So now is probably the fewest amount of revisions I've ever done. We used to do only tissue expanders. All of those patients go back 100% revision right.
100%
right. Then I did under the muscle direct to implant. I think that was probably like a 50-50. No, I'm going over the muscle cohesive implants with dermal matrix. And I think in this case, you can really trust that your chances of going back are like maybe in the 1-2 out of 10 patients max, depending on their natural layer of fat and thickness.
What were you saying?
I want to say something about the plastic surgery piece of it, because, a hard thing making the decision about knowing you have BRCA, and then when you decide you want to have double mastectomy, I mean, it's natural to wonder how you're going to look, especially if you're making these decisions and you're very young. And, from my experience in working with this team, and again, not an ad, no one's paying me to be here. This is literally my experience. You can come out actually feeling really great and like looking really great. And that's not the most important thing, but it is something that people consider when they're making this decision, how that's going to affect their life. And if they're not married and they want to date, and like these are all the kind of questions I hear all the time. And so I just wanted to say that it is now where plastic surgery is. You can literally have scars tucked underneath the fold of your breast and look like you have natural breasts. So,
and
I have to give.
And you should insist on that,
yes.
By the way.
Yeah.
Because I feel like a lot of the times, especially when people are diagnosed, they get bullied into doing things the way that doctor who happens to be seeing them does them. And that always makes me super duper mad, because ultimately it's patients that are going to change the system. So when women are kind of bullied into, no, we make the cut this way. Oh, sorry, you have no choice but a tissue expander. It makes me a little crazy because they do have a choice. But a lot of the time when you're diagnosed, you don't have the energy and the wherewithal to say, okay, I'm going to care about how I look and I'm going to find someone who does this, because you're shamed into, let's just treat the cancer, stop it. Exactly. Right. And I hate that, because what lasts with you in your whole life is how you look. And I know that sounds superficial, but we don't need to be reminded of that cancer or that gene even every day for the rest of our lives. We just want to make it do the least invasive thing possible and then get on with our lives and feel good about ourselves. And that produces less of a negative effect over time than being forced to make the wrong decision and then having to live with that decision. That makes me nuts. And it really victimizes the patient, and it produces a lot of negative juice down the road where they feel guilty and they feel bad and they feel like they were duped. And we don't need that, as we just discussed. Less anxiety is better. Feeling good about ourselves is better.
And I want to add is, it also, like, if it may look great, but if the plastic surgeons doing reconstruction isn't as good as they could be, it can lead to residual pain, you know? When I found Dr. Cassileth, I looked great, but I felt awful. And so, you know, there's two parts to BRCA journey. And so, yeah, you can look great, but if you don't have a plastic surgeon who is supporting your breast right, who is not stretchy, who might have put a really big implant in you when you didn't want one, which is something that happens a lot. And I know that Dr. Cassileth is so careful about making sure that your reconstruction is also the size that you feel comfortable with, because the women I hear from that are made bigger in their breast cancer reconstruction than they want to be, there's a lot of women.
I hear that so much.
Right.
It's so scary to me to say, well, I don't, you know, I want this size, and they wake up and their doctor, and I hate to say this, but usually male, is like, trust me, honey,
there's some good
you
males.
didn't want, no, there are, but I don't really almost ever hear it from a female breast. Like,
well, I actually just saw this name come up, J.S. Anderson, which I thought might be Jim Anderson at the City of Hope, who's a fantastic surgeon, and he does deep flaps.
No, there's wonderful, there's wonderful male, there's wonderful male surgeons out there. Don't get me wrong, but I almost never hear a woman say, I didn't want them this big, and and I woke up and she put them in and said, trust me, honey, this is going to look good. Yeah. I hear a lot of women, whenever they say, I didn't want these, and he told me when I woke up, trust me, you're going to want this. You're going to thank me later. And I'm kind of like, well, I think most women know their bodies and know what it's like to live with breasts as they are and the size they are. And I think they understand what it would mean to be significantly bigger or significantly smaller. Well, also, and to make a decision for them, like, is just not, I don't think anyone should do that, male or female. We
also can morph it. So, like, you know, a lot of women who had kids and they're in their mid 30s are like, they used to do this.
Tell me what morphing is. What's morphing?
Here, I'm getting there. Okay. Yes. Thank you. My sidekick. It's like a 3-dimensional camera, and you can actually say, here's how it will look if I put this size implant in you. And it is very powerful, because then you can say, I can make a visual expectation so that you know what you're going to get.
So show somebody a recreated digital image of what it would look like if.
That's right. Okay. Right. And then some women come in and they're sick of their big boobs, and they probably wouldn't have gotten a breast reduction, but they're ready to downsize. And we see that a lot too. And it's like, you know, if you didn't have breast cancer, what size breast would you use? Right.
What would you want to
and then someone texted in that bigger implants have a risk of encapsulation, but now with Keller funnels, total subdermal matrix, the size is not as sensitive to encapsulation as it used to be. The old data that we used to have, the bigger it is, the more encapsulated it might get, is not as true. That is, it used to be. Now, as the bigger it is, the more heavy it is.
We didn't know
the more support you need.
What the root cause of
we didn't. We didn't used to know what the root cause.
Now we kind of do. We think we do.
We kind of do. And the reason that capsular contraction is a firmness that can occur after reconstruction, the reason that it's more associated with a bigger implant is because all the data didn't come from reconstruction patients. It came from augmentation patients. Augmentation patients used to have a cut and shove a really big implant into that little hole. And what happens? It picks up biofilms on the way in.
And little germs get attached, and then your body starts to attack it. And there's a little skirmish, there's a little war, and there's just enough inflammation not to make you sick.
Right.
but just to cause a little bit of scar tissue.
And Alejandra knows this is like a whole nother webinar to talk about biofilms and breast implant illness and how to avoid it. But make sure you ask your surgeon about it, I think is enough to say for today, since we're talking to the BRCA community, and make sure your surgeon has a strategy to avoid you ever having a problem. Because if you can avoid having a problem in the first place, then you're the closest you can be to one and done, not uncomfortable, and not having long-term health problems. And that's what you want to have ideally, right?
I have a question for Alejandra, but one thing I want to say quickly is I want to make sure we talk about nerve preservation and nerves.
Oh, yes. Because
Please. That's something that is really big, really new, something that I don't think it could have been offered to you at the time you had your surgery, Alejandra. We weren't doing it then, but we are identifying the nerve roots and the nerve branches, and then we are reconnecting them with a nerve bridge so that the nerves can, it takes about 6 to 12 months, but the nerves can then regrow together, reattach, and suddenly we can allow sensation to be restored to a degree. It's not exactly the same as the sensation you have before surgery, but currently,
it's better than it would be if you didn't do it.
Currently, when we remove the breast tissue, there are some nerves that are coursing right directly through the middle of it, right through the highway, and we're taking all that tissue out, and so they're severed, and there's no connection anymore. So, blood vessels, like rivers, if you make a blockage, it's still going to flow. Nerves, like electricity, you snip the wire, and that's it. You can't. The electricity doesn't jump to the next wire.
Right.
So, but
it's actually pretty fun. And it works well with teams like our team where we work together a lot, because when Heather, Dr. Richardson's doing the mastectomy, she's looking. So I'll come in there a little before her, I'll look and find a nerve. And then sometimes she'll, during the mastectomy, find a large sensory nerve root coming right through the mastectomy specimen that can be salvaged. So it just happened to us the other day. We were doing a no implant type of reconstruction called a swim flap based on Heather's Goldilocks facts that she created. Great surgery for a no implant surgery. And she found a huge 2-3 millimeter nerve root coming right through the pec major muscle, that when I did the swim flap, I directly connected that nerve to a free nerve in the back of the nipple areolar complex. This is something that we started doing approximately a year and a half ago. So we have our 1-year data on that. And our first few patients we did, because it was so new, we did cancer patients, we did the non-cancer side. So it kind of gave us a control, because we had one side that had the nerve graft, one side that did not. And so all of the patients with the nerve graft have better sensation on the side that has the graft than doesn't. None of them are as if it never happened. And then some of them, it's excellent on both sides, just more excellent on the side with the graft. And so it's very interesting new material for us, because like we were saying before, the less damage you can do when you do the reconstruction, the better. So it's one less thing that we can hurt and we can give back to people. And I think, anything like that is positive and makes the experience less traumatic. So
I wanted to ask Alejandra, if you could go back and tell yourself something before you took that test, like one thing to expect or one thing that you'd want to know, or something you'd like to say to someone who may be bracing themselves to take a test, like what advice would you give them?
Well, I didn't see a genetic counselor. And so I think that having that support on the front end, and whether it's with a genetic counselor or building a relationship with your surgeon early on, so that you can have those conversations. I just think that would have been really helpful. But I would have told myself that it seems like there's so many obstacles ahead of you, because BRCA, when you're diagnosed, feels like, oh my God, my breasts and my ovaries, and how many other things do I have to do? And if you're going to have kids and you pass on the BRCA gene, all these different layers. And I would tell myself that it was going to be okay, take them one at a time, and I would get through it all. And that's the experience I have with the friends of mine who are going through it too. it's like just one at a time, and before you know it, you're on the other side of it, and you feel really good that you were proactive, and you can feel empowered through the journey, which is something that I didn't expect, to feel better on the other side.
And I want to ask too, how did the documentary, and how did that happen? Like, you had the wherewithal to say, hold on a second, stop, time out. I want to capture what's happening. I want to, the whole scope.
Yeah, no, I definitely didn't. Jonathan Silvers, who was a director of the documentary, his wife actually had BRCA and had a prophylactic double mastectomy. So he was already creating the film. but he hadn't finished it, and we connected halfway through it. And, you know, I told him, like, this is a big passion of mine. I want there to be women of color. I want this to be something that's really representative of this experience. And so we really came together and did it. But the interesting thing about having done it during my journey is it forces you to talk about these things in a way that, you know, it's easy to compartmentalize or to not deal with the feelings that are coming up. And so, you know, if anyone feels alone going through this, this is the film. I made the film that I wish I would have had at that time. So it's completely free, available on my website, or I think there's a link that we're going to put up, but it was on PBS last year, and you're able to follow 3 different sets of women who made 3 different choices based on their experience.
Yeah, it was very enlightening. Good job.
Here's a question that came up. What do you do post-mastectomy for screening? Are you done? Do you assume you're home free, or are you still watching?
This is tough. This is a tough one. Okay.
Yeah.
So
you know, I have my answer that I like.
Yeah. So the majority of doctors in the country, well, not maybe the majority, a lot of doctors who do what I do, they're the mastectomy surgery who's checking things out. Most of them don't do their own ultrasounds, and they do an exam, and then if they feel something, they send you off to a radiology center, they do the imaging, and then the doctor gets a report and reads it and goes, okay, well, they said they saw this. Most people that have mastectomies, their surgeon tells them, bye, tell me if there's a problem, come, you know, let me know a few years from now if you have a problem, and we'll take care of it then. Some doctors will have their patients come back and see them regularly, but they don't take any pictures, they don't do any regular imaging, and they just kind of feel and say, well, I don't feel anything. There are very few imaging centers that routinely are screening or taking pictures of patients who've had mastectomies. So a lot of those centers really don't know what to expect. Everybody knows what to expect to look at the tissue with all the different variations of what breast tissue looks like when you have breasts. But if you've had a mastectomy, a lot of these doctors don't know what they're seeing. They don't know what to look for. They don't know what they're seeing. There's tissue there, but is that breast tissue? And do we do MRIs? Do we do mammograms? One thing we all agree on is nobody needs any more mammograms. All the doctors universally have accepted that if you've had a mastectomy breast, there's no point in doing a mammogram on that breast ever again, with very few exceptions or just a couple of exceptions, and nobody really needs to know this. What I like to do with my patients is I do an ultrasound for a patient who's had cancer. I want to look at their cancer breasts every 6 months for 3 years, and then once a year forever, and both of their breasts forever. For patients who have never had cancer, I want to look at both of their breasts once a year with ultrasound. I want to look at the tissue that we've left behind. I want to see, how does the implant look? Does it look like there's any signs of capsular contracture, any fluid around the implant, any look like there's leak or rupture of the implant? How do the lymph nodes look? Is there any swelling or changes in the lymph node to suggest that there might be cancer cells growing in there? And then the tissue that we've left behind, how does that look? Does it look like I expect it to? Mm-hmm. And that's easy for me, and it's very reassuring. And there's lots of things that look funny. There's lots of little bumps and little things that can happen after mastectomies that aren't cancer. And it's important to be really comfortable at looking at mastectomy tissue so that you know what's within normal limits, and because the last thing anybody who's had a mastectomy is they want to be put on alert that there's something there. Right. So that you don't want to overexcite a mastectomy patient. It's like telling a new mom that there's something wrong with her baby. It's like looking at a neonatal ultrasound and going, uh-oh, you don't do that. It's
you know, plus the FDA now recommends we screen implants starting at 3 years annually. And so initially they recommended annual MRI. And so the plastic surgery community is like, hell's no, right? Because you know, these implants aren't rupturing or being prone to rupture for 10, 15, 20 years. So I feel like it's a very good compromise to say, okay, go back to Heather. She's going to make sure the tissue looks normal. She's also going to check my implant with ultrasound. That way you get like a 2-for-1 screener. And then if there is something we see that's more exciting that we want to, we'll check the implant, the tissue, whatever it is, with the MRI then. So you're not getting annual MRI 3 years after your breast implant every year is just overkill.
I've had patients in other areas say like, okay, I'm here for my ultrasound and my mastectomy flaps, and these other radiology centers are like, well, we don't know what to do with that. I guess let's order a mammogram and an MRI and an ultrasound, and oh gosh, we see stuff and now we don't know what to do with it. And so unless, and again, they're just not imaging mastectomies. So they don't know what is
Yeah.
normal to look at. So, you know,
This is her way of saying, okay,
I
most
don't
surgeons don't do ultrasound.
I don't,
She does.
Yeah.
So like, I think that's a very unique thing for you to be able to do.
I would say in general, if I was queen of
Yeah.
the universe, I'd say just have an ultrasound over your mastectomy sites once a year and find a
Right.
doctor that's really comfortable
Yes.
with doing that. And if they're like, oh gosh, we don't know what to do with this, don't go there. Just don't worry about it.
Right.
Just do what everybody else does. But I feel like it's
before we run out of time, I want to cover a couple of questions. By the way, I love my patient Victoria who logged on and said to remind us that ovaries. So tell me about this, like salpingo oophorectomy versus what's the current recommendations, ladies?
Right. I mean, I can say it or you can say it.
Well, why don't you say what you did, Alejandra, and then why don't you say what the recommendation is? Because you're the doctor.
You tell me what you did.
The doctor first.
Well, basically, so believe it or not, it's we don't really think it's the ovaries as much as the problem as is the tubes. It's the Mullerian duct tissue that's the problem.
That's so crazy, by the way.
It's the lining, and also that tissue is in the lining of the abdomen. So even if you get your ovaries and tubes out, there's still a possible very tiny.
Right,
it's still so important to go ahead and get the surgery done, and it can be life-saving. But the tissues, it's not just the ovary tissue, it's the tube tissue. So you have to have your tubes and ovaries out, not so much your uterus. You don't necessarily have to have a full hysterectomy, but the tubes and ovaries should come out because those are the cells that can spawn the ovarian cancer.
Mm-hmm.
So for patients that don't have their tubes or ovaries out, you should get a CA-125 and a transvaginal ultrasound starting at 35 to 40, and again, family history should play a part in that.
Mm-hmm.
And then also thinking about fertility. One of the things that your documentary did a really great show, a portion talking about, like, don't forget about preserving your fertility. If you're a younger woman and you've had really young members of your family die, consider starting your family earlier, or if that's just not practical, get egg freezing, egg harvesting, and make sure that your fertility choices are in order, because it's hard to do it last minute. Like, okay, here I am ready for my surgery, and oh, wait, I need to freeze my eggs. So doing that earlier, especially earlier when you're younger and you have healthier, stronger eggs. So if you decide to have a baby at 35, use those eggs that you had that we froze at 20. You're going to have 20-year-old eggs.
I mean, you have to be so mature to make that decision, though. I find
nowadays
that's tough.
Nowadays, it's really more about resources.
Who wants to do that? Oh.
Well,
the hormones.
I know a lot of young ladies who are who realize that
it's very smart.
Their partner, they haven't met their partner yet. And they're probably not going to meet their partner.
I'm glad to hear you say that.
And a lot of young ladies are realizing that they're prioritizing family, but they know it's not right now.
Yes.
And there's so many answers out there, and I highly recommend people to seek out. If you have any questions at all, just do it. Just go seek out the information and consider starting the fertility preservation.
Then you can just take your first step if you're ready. Another question was that options for avoiding capsular contracture. Let me go over those. That's really, really simple. From my point of view, it's implant is not allowed to touch the skin.
These are all things the surgeon has to do. The patient can't do anything. If the patient thinks there's something you can do, go ahead.
That's right. Implant is called no-touch technique, but people claim they do it, but literally we don't touch the implant. Implant comes directly out of the sterile container, goes directly into something called a Keller funnel. Your doctor really absolutely should use a Keller funnel. Unfortunately, many of these surgeries done in hospitals that aren't paying for it because it's not cheap to use it, but it's part of the reconstruction, needs to be done. There's lots of expensive stuff happening in surgery. And so then the funnel looks kind of like
giant pastry bag. Pastry bag.
Take a cake and frost it, and you actually put it into the reconstruction, which is fully formed within the patient, ready to go, and you take it and squeeze, poof, and it pops up on the other side, far away from the skin.
It never touches the hand.
In addition, before that's even put in, you do some antibiotic irrigation, and then the patient wound healing is critical. Why? Because if there's a little tiny delayed healing, remember I was talking about the bad situation with mastectomy flaps in the beginning, that actually can allow bacteria to come in and then become a problem with being around the implant, which can not just lead to breast implant illness, but also capsular contracture as your body reacts to that. So that means that the closure needs to be perfect. So usually the plastic surgeon trims the closure to make sure it has perfect blood flow. And I have become totally addicted to something called a Prevena vac. This is a a closure system. It's like a vacuum. It goes onto the surface of the reconstructed incision. So just like it's underneath here. And it suctions the wound edges together. I have not had, I'm knock on wood 500 times, one problem with an opening or dehiscence or infection since I started using it about 4 years ago, 3, 4. And it's like I started using it because I was getting a high level of radiated lumpectomy patients, and then went for mastectomy, which are notoriously high risk. And it just like works like a dream. And all these things are really, I think they're not really standard of care. So Keller funnel Provena vac and having great surgeons that like, you know, crosses on all the T's and dots the I's for you if you really want to prevent it. And it's not necessarily related to implant size, just the overall healthiness of the tissue.
And some patients are told, I hear from patients that they're told it's your problem, you make scar tissue.
Right. And like if you have a bilateral surgery and one side made scar tissue, explain that to me.
Yeah. Please. And that's not to say, I mean, you can do every single thing right, and sometimes things can happen for sure. I mean,
yes, that's true. It's
not always, there's no guarantee. Sometimes you can do absolutely everything right. And still, like you can have just transient bacteremia from brushing your teeth, and some germs can stick on the
but possible. I mean, the point is, you know, I think as surgeons, we deal with complications all the time, but if you do everything as well as you possibly can and correct, then at least
smallest
you've got the littlest chances possible. And then given the world of unknowns that is surgery, I think that's the most you can expect from your surgeon. Your surgeon should do it, and your surgeon should do it. And that's their job to do. And they shouldn't make excuses and say it's somebody else's fault. And I think that's very important to hear that as a patient.
What did you were going to talk about what your choices were in your path for your?
Well, I was just going to say, based with what Dr. Cassileth just said, when that question about what we can do from a patient's perspective, choose amazing surgeons and doctors like yourselves, because half the things you just said, I never even heard of, and I probably would never even understand what that even meant. But I love that. No, but I love that you know that. You know what I mean? Like whoever's doing my surgery should know all those things. And so like I guess that's what I learned in a lot of ways the hard way, you know. And it's so important to make sure that you pick the right doctor, because that will you will necessarily have to have more surgeries because of it if there's something that's missed or not done perfectly. So anyway, I just wanted to say that that's the only control we really have, but it's a big piece of it.
Right.
And no, I mean, with my journey, like I was one of those people who was thinking about the fertility part really young and doing fertility preservation because of something that also I would add, which is, and this is again completely based on people's preference or beliefs, but you are able to genetically test against if you do IVF to see if your embryos carry the BRCA gene mutation. So if you are going to have children, again, you could potentially not pass it on to your children. So that's a piece that, you know, even if, you know, someone is not necessarily doing it because they need to, you know, they may choose to do it because of that. So we could do a whole nother webinar on the fertility and the ovarian piece of it. But that's something obviously now that I think about a lot as far as the ovarian piece, because you don't want to ever neglect that part.
Right. Very, very true. And then Bedford does the post-mastectomy ultrasounds, not just you, but also the whole.
We do. Yeah. Our center is very, very comfortable at looking at mastectomy tissue, implants,
I'm sure I told you this, but whenever our patients go somewhere else, they keep trying to do mammograms on them. I'm like, there's no mammo to grammo. Stop it. This is not a breast you're looking at. We have fooled you.
It's tough. Other than, honestly, you just have to call this, if you're not here in Los Angeles area and can't come see us, I'd say you'd have to call an imaging center and say, I would like an ultrasound on a mastectomy. Is this something you do? Are you comfortable with that? And is it something that you do routinely? Or is it something that you never do? If you do them once a year, then I don't want to go there. If you're doing them a couple of times a week, you know, for whatever reason, then you know, you want a doctor that understands what they're looking at.
Yes, very true. Okay, we're going to wrap this up because we're coming up on 4 o'clock. Like, I can't believe we just talked for an hour.
I can.
Heather and I will talk all the time.
Yeah.
But I just wanted just to a huge thank you to Alejandra for just being available to your wisdom for our patients and sharing your journey with us. And please, as she already referred to her amazing film that she put forward really to help others and ended up also very much helping herself. So thank you so much. And we're just an honor and a privilege to be your doctor. Thank you.
Thank you so much for having me. And I am so grateful to the two of you. Literally, my life is in your hands. And thank you for sharing this information, creating and holding this space for all of us to be better, well-informed.
Excellent. All right. Thank you, guys. Signing off.
That was great.